The Everything PT podcast is sponsored by VALD Performance. VALD is the creator of the airbands for blood flow restriction therapy. If you are looking to stay up to date with today's post-surgical modalities and adding BFR to your clinic, please visit valdperformance.com.
This podcast is sponsored by CSMI, the maker of the HUMAC Norm isokinetic system. Purchase a new or refurbished machine, or you can even upgrade an existing system to bring it up to date with all the latest testing and training applications. Please visit csmisolutions.com to view all of their available products, including the HUMAC Norm isokinetic system, the HUMAC Balance portable computerized balance system, and Sportswear Online. CSMI, better data leads to better results.
Hello, and welcome to the Everything PT podcast with Matt Taylor and Daniel Bodkin. Please do not consider anything you hear to be medical advice. Just a couple of guys ranting about everything PT. Enjoy the show. Hello again, and welcome to the Everything PT podcast. I'm joined by Daniel Bodkin, my esteemed colleague here. How you doing, Dan?
I'm well, sir. How are you?
I am well. So you brought up a good topic today. Blood flow restriction therapy. That's a real hot topic.
Yeah.
Nowadays.
Well, it is in and of itself, but so I was listening to the Mike Reinhold show this morning, and their topic was on how BFR, or blood flow restriction therapy, is now not allowed for physical therapists in New York.
That is bonkers.
Yeah. So I figure, you know what? We'll talk about it. If anybody who listens doesn't know what BFR is, we'll kind of talk about that a little bit, how it works, how we use it, and then we'll talk about what's going on up in New York.
Yeah. So Dan, I guess there's some PTs out there that might not know what BFR is at this point. You want to try to do like a real brief summary of it, or I can?
Yeah. So essentially, if you want to get your patients strong, right, they have to be able to lift heavier loads, and that's to get actual hypertrophy. We're not talking about neuromuscular changes, right? So if we want to get our patients strong, which that's kind of one of the main goals of rehab, they have to be able to lift heavy loads, 60 to 80% of their 1 rep max. You can't exactly do that when you have an injury or a surgery. So right. A lot of the gains we're making early on in rehab by having to do light loads is all neuromuscular in nature. And we have to get those, changes, but we also want to get to hypertrophy as quickly as we can. So, bodybuilders have been using this for years. We tend to be a little bit more scientific about it, and we'll get into that when we talk about the safety. But we can essentially put a cuff on their limb, either the upper arm or the upper leg, and we can find out exactly how much pressure it takes to completely shut off or occlude all the arterial blood flow into the limb. All right, so that's 100% of their occlusion. Now, when we do BFR, sometimes we go 100%. We'll talk about that. But most of the time, we're only going 60 to 80% of that occlusion. Right. And the legs are 40 to 50% in the upper body. So we're not preventing blood from flowing in, but we're preventing it from flowing out.
Right.
When we do that, all right, and they do exercise at light loads, they're going to get an accumulation of lactate, of other metabolites building up within the tissues, right? They're also going to get swelling because it's filling up with blood. Right. So when we get that cellular swelling, when we get buildup of lactate, and when we get in hypoxic environment, low oxygen, all those things trigger a whole cascade. You're going to increase mTOR, reduce myostatin. Those are big anabolic pathways. We're going to get a kick. We're going to kick in an HGH release. We're going to get satellite cell proliferation to the area. We're going to get VEGF, which helps with angiogenesis, getting capillaries to regrow. What else is it? We're going to get type 2 muscles working. And type 2 muscles, they usually only get worked at the higher thresholds or the higher loads, but we're going to get them working with with the lower loads. All of these things are going to get those muscles beginning to hypertrophy at low loads. And I say low loads, I'm talking 20 to 30% of a person's 1 rep max. Now, that's a light enough load that a person should be able to do an exercise and continue doing the exercise indefinitely. We're talking 25, 30 plus reps.
Right.
Versus 60 to 80% of a person's 1 rep max, which that's typically what you need to get, hypertrophy. That's, 8 to 15 reps. So you get the same effects of lifting heavy while still working light. The other thing too is with BFR, you get these effects occurring in as soon as 4 weeks. In general, if we're just doing a strengthening program, don't even talk about injuries here, right? Just anybody who's untrained starts an exercise program, their first 6 to 8 weeks, they're going to get stronger by neuromuscular pathways. And it's only after those 6 to 8 weeks that they even begin getting into hypertrophy. Well, we can get into hypertrophy in only 4 weeks with BFR.
Yeah.
Right.
Yeah. No doubt about it. And you nerded out really hard there, dude. That was awesome. Like you got a lot of your
one of the lectures in my rehab class for the athletic trainers is on BFR, and it's actually pulled up in the background. So I made sure I went through and looked at the science a little bit. Like I said, I'm a meathead that can memorize some facts.
Nice. I summarize all that by calling it the metabolic overload. That's the benefits of getting that metabolic overload. If you've ever done a crushing workout, like I think about in the gym relating to strength training with 21s, like you just go in the 7 lower, 7 higher, and then 7 full range of motion. And then you get that huge pump in your muscles, but you can't do that when you're injured, but you're able to get a similar effect of that huge muscle expansion. There's a lot of blood volume to the area. I remember just when my buddy Kyle and I were trying this out in the clinic, I put it on my leg and I did 30 straight leg raises, on the thigh. And then I went to 15, 15, 15 after that, the prescription. And I took my girth measurements. I do lymphedema, so I'm pretty more accurate than most, 4 centimeters greater on the side with the cuff. So there's a lot of tissue expansion, a lot of blood flow to the area. Just no super sciencey stuff there, but definitely a massive amount of blood flow to the area.
Absolutely. And, the biggest thing that people talk about as far as safety is the question of, are you increasing somebody's risk of a blood clot?
Sure.
When you're doing BFR. It actually turns out that you have an improved or reduced risk of a blood clot with doing BFR.
Right. So
study after study shows that.
Yeah. I got a couple patients in mind that have had issues with, coagulation and things of that nature. And they have had blood clots. And obviously you wouldn't want to do it with someone who's, got that Wells rule that's high and, or anything of that to that nature. But ruling out some quick contraindications, we can touch them since we're here. Obviously DVT, history of clotting issues or disorders, cancer distal to that, the area in that limb, possible medications that you're on that you with anticoagulant and things of that nature you might want to be aware of too.
Pregnancy.
Yeah, we don't do anything to pregnant women, right? Yeah, for sure.
It's essentially the same list that you get with many of our other modalities that we use in physical therapy.
Great point. Yeah, ultrasound, E-stem, all that fun stuff.
And part of being a professional and being a PT is looking for those rules, looking at those contraindications and knowing when it's appropriate to apply it to the patient.
So you're saying that it would be better for a very well-trained professional to oversee that rather than just someone buy them off the online and just put them on their arms.
I might be indicating that. Looking for a way to improve sport-specific training with your athletes? Then you have to check out Blaze Pods. Blaze Pods is a neurocognitive reaction training intervention that can be incorporated into your sessions for patients throughout the treatment spectrum. Visit blazepod.com, enter code EVERYTHINGPT at checkout and save 15% off your order today. Hey, all you rehab specialists out there, do you have an isokinetic dynamometer just sitting around your clinic not being used? Little known fact, isokinetic machines that aren't used regularly are at higher risk for bouts of sadness. Help your machine out and take CSMI's newest CEU course, Isokinetics 101 online, created by me, Daniel Bodkin, and learn how to use all the exercise and testing applications available on your machine. With new and exciting rehab techniques in your toolbox, your sad isokinetic machine can become an active member of the rehab team again and regain its happiness. Isokinetics 101 online by CSMI has been approved for 8 credit hours for athletic trainers, physical therapists, and physical therapy assistants. Contact your state board for details on specific requirements. This course is available at humacnorm.com/courses/isokinetics-101.
Yeah.
All right. So that's what BFR is. Now there's a lot of different ways we can use BFR, right? Let's just first talk prehab. Right, somebody who had an ACL or toward their ACL, somebody's going to undergo a total knee surgery. Somebody who's going to undergo like a rotator cuff surgery. Right, we can have them do exercises, basic exercises that they probably already should be doing as prehab, but with cuffs.
That's a good idea. I have not given that for prehab yet, but that's not a bad idea at all, though.
Yeah. I mean, typically in our setting, we won't see them prehab. And sometimes they'll come in prehab just to get a basic home routine. But if you were to have, if you are in the setting where you're working with athletes or you have somebody that comes in for a month of prehab prior to surgery, BFR is a great way to go.
Yeah, that's not a bad idea at all. I never thought of that before.
All right, post-op, right? Somebody who just had a total knee or an ACL. One of the things we can do is just simply pump up the cuffs, and you can go all the way to 100% of their occlusion. They just lay there. It's called passive ischemic. And so what they're going to get with that is just the cellular swelling by getting the fluid buildup in the leg. That's going to make the muscle cells themselves actually swell. And that's one of the main triggers. And tons of research shows that even that just by itself is going to start these cascades of healing.
Man, you're dropping some knowledge on me today.
Like I said, man, when you have to put together lectures, that's the thing I learned. When you have to actually put together lectures, you need to make sure that you're like on the right path because you don't want to be called out on it.
Clinically, it's the most impressive I've seen you yet here. But
every once in a while.
Pretty good, buddy.
But then even going beyond that, just having somebody do, you can do E-stem along with that. So you just put, a 10, Russian E-stem on the quad while they're pumped up. And it doesn't even have to be 100%. You could go to that 60 to 80%.
Now, I do quickly want to mention with total knee replacement, I think it takes a specific individual to tolerate that early on, because we have some people who just their leg is way too big. It's way too large here in Charleston, West Virginia. And it just doesn't fit. It doesn't work, the proximal thigh. But a lot of people like our savvy veterans who are like, the guy I'm talking about, who will do anything to get better faster. Yeah. Wonderful person to do it with.
And you also go back to, what is your goal of the intervention and what is your goal of the therapy that day or that week?
Right.
If they don't have the motion back yet, you should probably concentrate on the motion.
Yeah.
And, so again, the right patient, the right time.
Sure.
And then take the cuff away, right? Have them start some of their basic rehab exercises, straight leg raises, full arc quads, mini squats, right?
Right.
Once they can get to the point where they're able to do them and perform them well, you then put the cuffs back on.
Good idea.
So a typical, and you don't have to always do this, but the typical active or exercising rep set scheme for BFR is doing 75 reps. It's a set of 30 and then 3 sets of 15, all with up to a minute in between. So I'm not going to put, cuffs on somebody for mini squats if they can't at least do 75 mini squats yet.
Makes sense.
Right. So it's a way of getting a significant amount of load. Again, it's a metabolic load without actually putting on a significant load. Right?
Yeah. So Dan, you've done this obviously way more than I have. We just got them after we've had them for about 3 months now. So we put them on, I don't know, maybe a dozen patients or so. And I like it. So I can definitely make a good argument for putting BFR cuffs on first, and I can see you doing it last as well. So what are your thoughts about putting them on first or last?
What do you mean in the session?
In one treatment session.
Here's the thing also, I forgot to mention, when you put cuffs on, it's really uncomfortable. It's extremely uncomfortable.
For sure.
You get a huge reduction in pain. So you're lowering that pain threshold in the patient. So they might come in and, doing an exercise, their pain might be a 6. Right. After doing, even just with a passive ischemic modality with the cuffs, now their pain threshold is going to be significantly lower. So you might even say, you know what, let's put the cuffs on early to help reduce that pain threshold.
Sure. So my old strength and conditioning head goes to, we want to get you on your feet and do your squat, do the hardest things first, your multi-joint compound movements or whatever that is on your feet. And then we work our way down to it's kind of open chain stuff towards the end. So I can definitely see how you would say BFR for last,
absolutely. Here's the other thing too, I didn't mention is you can do cardiovascular exercise with cuffs. So putting somebody on the bike, right? Having them pedal, for 10 minutes, or they try to go up to 20 minutes. You can even cycle it. They can pedal for 5 minutes on, 1 minute off, or 10 minutes on, 2 minutes off, right? You're trying to build it up to where they can get up to 20 minutes. They're going to get a big increase in cardiovascular, now the science is gone because I didn't look this part of it, but they're going to get a big cardiovascular effect as well as the local muscular effects of it. So, if somebody can get on the bike, they might not be able to do mini squats with the cuffs on yet, but they can ride the bike for 15 minutes. If somebody can get on the treadmill or walk, you can put the cuffs on as they walk. But again, somebody's getting they have any gait disturbances, you don't want to do that. Or if, they walk great for 10 minutes and then they start to get a limp because they're fatiguing, take the cuffs off.
Yeah,
all right.
For sure.
Another way you can use it is because ideally our patients can do a heavy load, right? So if they can do a heavy load, they're going to get more out of doing a heavy load.
Right.
But you can also use it as supplement, right? Any of our trained athletes or somebody that's at the higher end of their rehab, on their off day, we can have them come in, or we can even let them go home with cuffs, and they can do, they can cycle with cuffs. They can do a workout with cuffs on their day off to help with recovery.
Sure.
We can have them do a full workout, let's just say legs. So they get through a squat exercise, a hinge exercise. And now at the end of their workout, we want to throw on the cuffs to get some supplement work. So we can isolate the quad, isolate the hamstring.
Yeah. You mentioned a lot of science and a lot of articles earlier on. I went to CSM this year and it just everywhere you looked, BFR. And then this group from Delaware, this group from Pittsburgh, and just tons of people doing research. Yeah. And just because there's one article published does not really say much about anything, but we're seeing over and over again, these studies are reproduced, they're replicated, they're performed, and over again, these people 0 to 12 weeks that have BFR training, they have faster outcomes. They have better outcomes too. Yeah. It seems
you can even do isokinetic exercises with BFR.
Yeah. I
don't know because I know you're taking the course I made. I don't know if you've gotten to that part yet, but you can do it. Doesn't mean you need to, but you can do some BFR isometrics, BFR isotonics, and BFR isokinetics. So a lot of different things. I even saw a video you posted the other day. He was a gentleman doing, he was just doing active range of motion.
Yeah, just shoulder press.
It was a functional exercise, reaching up with cuffs.
Beautiful. It's beautiful. He had a rotator cuff tear he's coming back from. And it was great. He said, that's the hardest thing I've done in my therapy since we started. I said, I know.
Yeah.
I know,
and man. It's functional.
Yeah.
Let's say somebody early post-op with the shoulder, right? You can put the cuffs on their legs. Have them ride the bike, have them do, mini squats, have them do a leg press with cuffs, because it's not just local to where the cuff is. Everybody thinks it's only getting distal to the cuff where you actually get the occlusion. You get the same effects proximal to the cuff. You get a crossover effect. So I can do an exercise on, my right leg or my right arm, get the effect on my left, or I can do lower body exercise and I get the same benefits in my upper body.
That's cool. That's
Yeah.
cool. I'm glad you told me that. We spoke previously about that. I remember.
Mhm.
That's good to know. So changing gears here.
Yeah.
So what are your thoughts about the whole New York changing of the laws? And like PTs in New York are no longer able to do this with their Practice Act changing.
So I want to know why.
I have a big question. I mean, maybe there was someone with lots of money that had BFR and then got a clot, or had a DVT that turned into a P. Something
I don't
crazy.
know. It might just
Probably
be
happened.
lobbying too.
But why?
I don't know. And again, I can't make assumptions. I do that all the time and get myself in trouble.
Oh, it's fun.
I want to know why they decided that they shouldn't be. I would say PTs are the perfect person to do PFR.
I'm thinking about the chiropractic field, and that's really not a battle that they want, or athletic trainers. You are an ATC, Daniel.
Yeah.
Can you think of any perspective from the ATCs? Yeah, I can't.
No, not at all. Because BFR can be used well beyond just with athletes. If you have somebody, and somebody who is very weak, an older person, not a lot of muscle mass, you can do some of those earlier, easier interventions to help move them along. But then so you mentioned chiropractors. I took the course from Smart Cuffs, right? And it was actually one of the guys who were the Prehab guys came and taught my course, which is really cool getting to meet him. And I would love the Prehab guys to come on on our show. But one of the people who developed their course through Smart Cuffs is Ed LaCara, and he's a chiropractor in Dallas. And so every week he does a little BFR Tuesday. Usually 15 minutes, he kind of gets on, he answers questions, or he'll just kind of go through one of his lectures. So I listen to that every week. So chiropractors, if as part of their practice, they're also doing rehab exercises, they're great to do this too. Athletic trainers, personal trainers too, right? They can use this all the time as in their scope of practice. I just don't know why you would take the person who is the most likely to pick up on any red or yellow flags, the person who will dose it correctly for a broad population and take it away. So again, I just don't know why.
Yeah, I don't get it either. And you think about the physicians, if the sports physicians would want to do this, but they have too much on their plate already. Yeah. With medications and making rounds, and they get sued more than any other profession in healthcare. So they don't want this. Probably, I shouldn't sound so, dichotomous, but and definitely I don't feel like they want this either. So
no, my only worry is this going to have a domino effect? Yeah. Are other states going to follow suit?
Yeah, kind of like the how Medicare just slashed their fee schedule, and now we're seeing a trend in private practice where pay is also decreasing now from different providers too. So I hope not. I really hope not. I hope our APTA, I feel like they recognize this is a good thing. This is probably something to dig their heels in and fight against, and I hope they can. So,
well, then also, if you think about it like this, right? A large portion of my clients aren't physical therapy. They're personal training, but at one point they were physical therapy. So even you do have the same where you have personal training in your clinic. So can if I'm working with somebody who's strength conditioning, wellness, personal training, can I do BFR with them?
Whoa.
But not with my PT patient?
This has come up for me a few times because I have, I'm a personal trainer too through the NSCA, and I can go across state lines. I can call people on the phone and have interviews with them like we're having on Zoom right now. And I can't with physical therapy because of the whole licensure thing. And it's a very similar thing with BFR too, like I have gone through way more schooling, way more qualifications with PT, but probably have a little less restrictions with personal training,
Yeah, no, I can totally see if regulating body came back and said, you can do BFR if you have, hopefully it's just taken a course, something that shows that you understand, the uses, the indications, contraindications. So I totally get that, but just to take it away completely, that's, I don't get it.
I haven't seen the APTA's official statement, but I was just reading before we came on, and they support BFR, and they encourage you to take a course. They feel like it's in our scope of practice to do, which is good to hear.
Oh yeah. Right? And in my isokinetic course, I come out and I say, this is not because I do just a portion of a BFR in that course. And I say, this is not intended to replace a full BFR course.
Right.
But if you use BFR and you're trained in it and you use isokinetics, this is how you can marry the two together. But I absolutely 100% support going to a course or taking an online course.
So, who I know Smart Cuffs is who you did yours through. Obviously we are real big fans of VALD with the smart bands, VALD Performance, everything. I'm very impressed with them as a whole. Shout out one of our sponsors, but who else does it? The Owens Recovery Group, known to be, has the only one that's FDA approved. I think that's kind of weird that the FDA is regulating something like that, but that's just me, personally. Yeah. But I know they do a lot of good research and a lot of good science. They are definitely seems like the leaders in blood flow restriction, although it's very costly for their machine and their course.
And, I'm always one to, I sat on BFR for a while. I think from the first time I heard of it to when I actually started implementing it was like 8 years. Okay. I was like, I don't know, I'm not big to jump on a bandwagon. Yeah. So I sat on it for a while, and just the research kept coming out showing it was beneficial and safe. And then I finally joined in on it. So we'll see where it goes and, the different uses of it. But, and I'm sure we're going to see this controversial aspect of it evolve. Yeah.
Do you think for guys like you and me who are like, you're an athletic trainer, I'm a personal trainer. This is kind of a weird question, but do you think like you'll use your athletic training licensure to perform BFR separate from therapy? I don't know if that's even possible to clock in and clock out. That's kind of a weird thing. I'm not
sure.
It's kind of a gray area too.
Crossing a gray line, and
I don't think it's wise to do.
Yeah.
Personally.
One way that I use it right now is I send it home with, so I have a young lady who we've been working on her. She had an ACL reconstruction. And, my model is to set up a gym in people's homes and I train them at their house. So she does BFR 1 to 2 times a week on her own. She knows exactly what her pressures are. She knows how to do, the 75 rep scheme. She knows what weight to use. So that's how one way I use it.
Okay.
Versus, taking it to the patient, which, I do that as well. But I like to send it home with them because, again, I'm on more of the, post discharge, return to sport end of it. So a little bit different than how I approach it now than when I was in the clinic.
Sure. Just thinking out loud ways to get around things, and because you can't include it in any of your notes. But it's one of those things where if 0 to 12 weeks, would you say you had an ACL, would you rather your quad index be, 60 or 70 or 30 to 50? No, that's different for everyone, I realize. Yeah. But that's what those guys from Delaware, man, that's pretty much what they're showing, though. Those numbers are real.
In my opinion, it's not the surgical technique that's holding back ACLs. It's how long it takes to get the strength back.
Yeah.
And if we can speed that up, we'll have, I don't want to speed up getting back on the field, but I want the time that they get back onto the field to have more strength. So I think that's, that's a whole other conversation for another day.
Yeah, for sure. We can go
a lot of directions. If you want to learn more about BFR, what's the course you took?
Oh, I took Mike Reinold and Dan Lorenz have a course out there. It's great. It's like $300. It's quick. It tells you down and dirty what you need to know. And we bought those air bands from VALD Performance. If you guys haven't, go ahead and check their website out. It's an awesome thing. And they're very affordable. For less than $1,000. You can add an incredible modality into your private practice, like, like your mobile. And I have a brick and mortar place here in West Virginia, but it's a really, really good thing. I wish our field would get behind something like this more instead of, passive modalities of the past.
Yeah. I took the Smart Cuffs course. Again, it was Mike from the Prehab guys taught it.
Okay.
And it was a live course. They now have an online course. They developed that with COVID. So I took that, and I also bought a clinical set. So I have, all the way from size 1 to size 5. So I have a whole clinical set now, and I got, a big discount on that by taking the course. But I think I was the only PT there. There was also a PTA, a couple athletic trainers, and everybody else was a personal trainer or somebody who just wanted to do it for their own personal strength and conditioning.
Fascinating.
I think there were 5 people there that they weren't even in the rehab world. They just wanted to do BFR for themselves and learn it.
That's interesting in and of itself, right? Very
exactly.
Cool.
But
hey, what else I want to talk about is the dosing of this. And this is good because I know you've done a lot of this. So I know, let's say our patient comes 3 days a week right out of the gate after ACL. We're going to give them 30, 15, 15, and 15 reps a dose, right? As recommended. Are you doing that every time you see them? Or are you doing it once a week, twice a week kind of thing?
So again, you got to think of them. What is the goal of the intervention? For that 10-minute time that you're doing it, what's the goal for the day, and what's the goal for, this phase of rehab? Right. So if they come in, their range of motion it sucks. You got to work on that range.
Right.
You got to do some manual stuff with them. You got to work on balance and proprioception. You got to work on closed kinetic work. In my opinion, you got to do some open chain isolated exercises. If there's a way to improve what the exercise they're doing with BFR, absolutely, they can get it every time. Absolutely.
Okay. That makes sense. Okay. That was the last thing. I just want our listeners to just have a really good idea of what it is and what it looks like to implement it in the clinic as quickly as we can here. But I encourage the courses too. There's some really good online stuff out there for people. So really encourage VALD Performance though. These guys are great.
Yeah, absolutely. Go VALD.
Yeah, go VALD. Anthony Senecor for the win. Well, cool. Daniel, we get it all here. We missing anything on BFR?
I think that's good for today.
Okay. Yeah. If you're listening, NSE out there, I got an NSE that listens, I know. So that's it for today, but we'll see everyone next week. Thanks everybody.